Good afternoon, everybody, and welcome to Care Connection, the free live webinar. Today's topic is going to be problems with eating in dementia. Before we begin, I want to let everyone know that the presentation is in listen-only mode. That at the end of the presentation, you could type in your questions or comments, and I will read them to the presenter. In addition, on the right-hand side in the control panel, you will find the handout from today's presentation. Today's guest speaker is Dr. Weintraub. She's on the faculty of UCLA in Internal Medicine and Geriatrics. She has had an appointment to the medical staff at the Greater Los Angeles Veterans Affairs Medical Center since 2001. Dr. Weintraub has served as the director of the Geriatric Medicine Fellowship at UCLA and the director of the Special Advanced Fellowship in Geriatrics at the GLA-VA since 2008. Dr. Weintraub, we are so happy to have you as a guest speaker for this very important topic. Could you please begin today's presentation?
Thank you very much for the introduction. And I just wanted to say before I start, well, first of all, thanks to everyone who's listening. And this is meant to be a general discussion of a topic, and I'm really not going to be able to answer any specific questions about any individual medical problems that anyone might bring up. That would be something to discuss with everybody's private provider. But anyway, thank you for listening. I'm going to be talking about a topic that I'm a little bit passionate about. So I apologize if I get worked up at any point. We're going to be talking about eating problems in people who suffer from dementia. As people progress through this disease, or through this syndrome, because dementia is a final common pathway for many different diseases of the brain. People lose various skills, usually in a predictable pattern. And the ability to feed oneself is usually the last independent skill that a person with dementia loses. And by the time someone is suffering from advanced dementia, 86% of those people will have problems with feeding. Swallowing is an extremely complicated process. It is something that we don't usually think about because we do it, constantly and fairly reflexly. But it involves about 50 pairs of muscles. Some of them are under voluntary control, and some of them are under involuntary control, meaning that they function as reflex once some other processes begin. And this is just a diagram of a cross-section, really a sagittal section, which means that it's through a head, up and down, person looking sideways, nose pointing to the right. Just to give you a sense of how complicated this seemingly simple process is. You can orient yourself with the teeth, I think. They're the pointy white things towards the right. And so when we swallow, we start with putting food into our mouths through our lips, sometimes chew it up if it's solid, sometimes not. But you see the amazingly large pink structure in the middle, which is the tongue. And the tongue is responsible for sort of gathering whatever it is that's in our mouth into a cohesive lump and moving it backwards towards the soft palate, at which point we have to close our trachea, which the breathing tube, which is in the front of the neck, and open the esophagus, which is behind it, so that the food goes down the right tube. And that's as much as I'm going to say about that, but it is very simple to have that go awry in all kinds of different ways. Just as people, when who have dementia, as their disease progresses, they forget how to get dressed, they'll eventually forget how to walk, they also forget how to swallow properly. And towards the end of this devastating illness, people lose weight, they become malnourished, and they may suffer from aspiration pneumonia as a consequence of this difficulty in swallowing. I'm just going to go back a slide because, as you can see, the trachea, which goes down to your lungs, is just right in front of the esophagus, and there's it has to close at the right moment in order to keep the food from going down into the lungs, which can result in an aspiration. The people who tend to be the specialists at evaluating these problems are speech therapists. And the great thing about them is that they can, well, first of all, they're very smart, but second of all, they can also help figure out for each individual person if there are consistencies of food and liquid that might be safer for an individual person to deal with as they're chewing and swallowing. There are two kinds of swallowing studies that are usually done. One is at the bedside, and one is a fluoroscopic study. So it's done in X-ray, and it's with barium. It's also called a barium swallow. The bedside study, in a bedside study, the speech therapist will watch someone eat and drink and bring various consistencies of food and see if some of them can be managed better than others. They just kind of get a quick and dirty look at how someone is doing when they're swallowing, if their Adam's apple rises correctly at the right time. That's what closes off your esophagus. And then, excuse me, sometimes they will suggest a fluoroscopic study. And what they do there is people go to X-ray and they make live videos are made of people eating and drinking different consistencies of food. And the food is laced with barium so that you can actually see it move as someone manipulates it in their mouth and swallows. And you can see if it's going correctly. The advantage of having these studies, as I said, is to see if there are some consistencies that are safer than others. In people who do not have dementia but who have swallowing problems for other reasons, these studies can also help a speech therapist prescribe exercises for someone to do to try and strengthen certain muscles, or they can give people techniques to use when they're swallowing and teach them these techniques. But unfortunately, when you're dealing with someone who has dementia, these techniques don't work because people who suffer from this disease really can't learn. So in a person with dementia, what you're doing is just looking for safer consistencies. The other thing that can help is feeding someone extremely slowly with very small bites. And this can be a little tedious, but it's also a way to have face-to-face interaction with a person who suffers from dementia. And this can be a useful way to go. What about weight loss? So, unfortunately, dementia, which can last for many, many years, is eventually a fatal disease in and of itself. If someone who has dementia does not pass away from a different illness, they will pass away eventually from their dementia. And one of the things that precedes this final stage, or that accompanies this final stage, is kind of a relentless weight loss. And just as people who have cancer have sort of higher metabolisms and lose weight, so do people with dementia. And, we spend our professional lives as doctors telling people what they should and shouldn't eat, that they should exercise, that they should eat healthy food, that they should cut down on their fat intake, and so on. Well, when someone has dementia and starts to lose weight, that all goes out the window. People with dementia should eat whatever they are willing to eat. Ice cream diet is fine. The other thing that happens to all people as they get older is our senses of smell diminish. And when your sense of smell diminishes, your sense of taste goes along with it. And someone who has this happen as they get older and who does not suffer from dementia is still going to know, well, I should eat healthy foods, even though everything tastes a little less interesting to me. Well, someone who has dementia is not going to do that. They're only going to eat things that are particularly delicious for them. And usually people's sense of sweet, the ability to taste sweet things persists. And so sometimes really people just eat a lot of pudding and ice cream. And if that's what you need to do to keep someone from wasting away, that's fine. There are also some gadgets that can be used to help people with various types of problems. And I have some pictures of these things. If someone has a tremor and it makes it difficult for them to feed themselves because when they put something onto their spoon or their fork, it flies off, there are weighted utensils that will change the speed of the tremor and slow it down so that the likelihood of getting the food from the plate into your mouth increases. There are also bowls with lips and that have rubber bottoms that will keep them that will keep the actual bowl from moving around, and you can push against the lip with a spoon. For people who can't use their hands for one reason or another, there are wrist cuffs that can attach a utensil to it. And then for people who need to be fed, the simplest way to make sure that they are not being rushed and that they are not being given bites that are bigger than they can deal with is to use a long-handled baby spoon. It's very hard to rush someone when you're giving them little tiny bites from a baby spoon. So these are weighted utensils. In addition to the grip being large, which is also good for people who have arthritis, you can get utensils with large grips that are not heavy. And so people who really can't make a tight fist can use them more effectively. But they can also be weighted. And as I said, if they're weighted, they're useful for people who have tremors. These are plates and bowls with lips on the edge. And so you see, if you have a spoon, excuse me, and you're pushing towards the lip, it will keep all the food from falling out of the plate and onto the table. In addition, these, for the top two, you can see that they have sort of suction cup bottoms, And the third one has a non-slip bottom so that the plates themselves will not go skittering around the table. This is the cuff. It can be either around the forehand or around the wrist. So for someone who can't use their fingers but can still manipulate their arm, they can feed themselves that way to preserve as much independence as possible, which is always a goal. And then for people who really cannot feed themselves anymore, there is the little tiny spoon. And that really does help people manage swallowing because they have a smaller quantity in their mouth that they need to deal with. The other thing that happens as people progress in their dementia is that sometimes they'll be given a spoonful of food and they kind of move it around in their mouths and then they just aren't quite sure what to do with it and they forget to swallow it. And so it's useful to have a look in there periodically to see if there's food remaining in the mouth, because even if you're giving people little bites, if they're not swallowing them, the end result is lots of little bites are like a big bite. What about different consistencies of food, and why are these sometimes suggested? So just to orient you a little bit, sometimes a speech pathologist will recommend pureed food. Pureed food is like pudding. It's baby food. You can puree anything. For those of you who ever made baby food, you can puree chicken soup, and it's actually really delicious. Then there's diced consistency, which is very small bits of things that are soft. And then there's soft food, which is like mashed bananas. For liquids are particularly complicated to swallow because when you put them in your mouth, they don't hold together. They splash around all over the place. And it is complicated to get the whole volume down at once without any of it slipping down into the trachea and into the lungs. So thickened liquids are actually easier to swallow because they hold together better than a thin liquid. And there are so other than thin liquids, which are normal liquids like water, there are two other consistencies that are sometimes suggested. One is honey thick, which is exactly what it sounds like. It's like honey. It doesn't feel like a liquid. It doesn't look like a liquid, but it's a liquid that has had something added to it. Sometimes they're cornstarch based. There are different products that you can add to liquids to thicken them. And then there's nectar thick liquid, which is a little thicker than water. It's like peach nectar or apricot nectar or sort of a thick tomato soup, something like that, which is also easier to swallow than a regular thin liquid like juice or water. And this, again, is just giving you some examples of these. For puree or pudding consistency, there's yogurt, cottage cheese, even though it has a little bump in it, creamed soups, and then, as I said, pureed whatever. Then there are ground foods like ground meat, canned tuna, mushed up vegetables, and sometimes these things can get pretty dry, which makes them hard to swallow. Older people in general tend to have less saliva production, and so these things may need to be moistened. And then there are soft foods that kind of stick together, like scrambled eggs or meatloaf or things like that. And then there are your regular complicated texture foods that are the hardest things to manage, like pasta or cold cereal. And then, of course, there are the the hardest things for people to manage, and this is not just people with dementia, is hard foods like, a steak, because you have to chew it up first. So if you don't have any teeth, that's difficult to do, but that's not specific to people with dementia. The really hard, difficult foods are things that are stringy or flaky, like toast, because it makes crumbs all over the place and they kind of fly around inside your mouth. Food that comes in little bits, like rice, or dry cooked beans, nuts. Foods that melt can be difficult because they turn into thin liquid in your mouth. And then things that kind of stick to the inside of your mouth, like, peanut butter or mashed potatoes, things like that it's hard to move into the back of your mouth as you should. So, what about straws? If you ever visit anyone in the hospital, you will you'll probably notice that there are straws everywhere. And as you walk past anyone's room, you will see straws sticking out of cups. Well, straws are not your friend. The problem with a straw is that, as I said, what you have to do when you get something into your mouth is kind of pull it together and move it as a unit into the back of your throat, so that when you close off your trachea, which happens only for a brief period, all of the stuff that's in your mouth will go down the correct pipe. Well, when you drink liquid with a straw, it tends to shoot droplets all over your mouth. And those are very hard to recollect and kind of glom into a bubble that you can then move back and swallow. So when I sometimes work in the hospital, which I sometimes do, I basically walk around, make rounds on my patients, and take away everybody's straws. Straws are dangerous. It's just, and the plastic ones are particularly bad for the environment, but that's beside the point at this moment. Straws make it very hard to swallow and very easy to aspirate liquid. I'm just going to, before I go on to the next little topic, I just want to say the other thing that you can do, and I neglected to make a slide about this, to try and prevent aspiration pneumonias, which are infections in the lung, is to maintain excellent oral hygiene. So we all aspirate a little bit all the time. Sometimes you'll just get the sense that something went down the wrong way. Even when we're not eating, we aspirate. And what we aspirate is the liquid that's in our mouths. So if you have a lot of bacteria in your mouth and you aspirate that, you have a much greater risk of developing a lung infection than if you have very little bacteria in your mouth. People who have no teeth have a better time of it because the really bad bacteria tend to live in the spaces between your gums and your teeth. So anyone who has teeth really needs to have very good hygiene. And even people who don't have teeth need to have their mouths rinsed out periodically so that they are not harboring harmful bacteria, potentially harmful bacteria in their mouths, which they can then aspirate into their lungs. Okay. I'm now going to talk about feeding tubes because anyone who cares for someone who suffers from dementia needs to be educated about feeding tubes. And it is not because I advocate for them. We just need to understand why they are recommended and the pros and cons. So a feeding tube is a device that bypasses the need to swallow. There are two kinds. Well, there are really three kinds, but one kind is very rarely used, so I'm not really going to talk about it. There is a nasogastric tube, or an NG tube, and there's a PEG tube, which is a percutaneous endoscopic gastrostomy tube, and I'm going to explain each of these individually. A nasogastric tube is a tube that goes through the nose, down to the back of the throat, into the esophagus, and down to the stomach. The advantage of it, if you're trying to feed someone through it, is that it can be put in at the bedside. Nurses can put them in, doctors can put them in. The downside of these is that they're extremely uncomfortable. They can only be used for a few days because otherwise they can cause erosion of the tissues inside the nose, and they actually increase the risk of aspiration because, I'm going to go back a few slides to the diagram. I'm going to go back a lot of slides. Here we go. Because what happens with the nasogastric tube is, I want you to imagine, you can see the nostril, the tube goes in there, slinks back to the back of the throat, and then goes down into the esophagus, and it holds the esophagus open all the time. So the trachea can't close off. So you've got this opening all the time. Usually when we are not swallowing, our esophagus is closed and our trachea is open, so we can breathe. But here in this picture, you can see the nasogastric tube is going into the nose and then through the nasal cavity, down the throat, and into the stomach, holding the esophagus open all the time. So you can't close it while you're breathing. So it actually increases your risk of aspiration in a couple of ways. As I mentioned before, we can aspirate the food that's in our, not food, the liquid that's in our mouths and the bacteria that's in our mouths. So if the esophagus is open all the time, you will be constantly aspirating what's in your mouth. Additionally, if you are fed through a nasogastric tube, you'll be fed liquid food that goes down into the stomach, and the stomach can get over full, especially in someone who's ill, and the stomach doesn't empty as usual, and you can get reflux of the food back up into the throat and then down the trachea because you can't close off the esophagus, as I said. So these tubes generally are used only in very short term in the hospital for people who are very ill for one reason or another. They can also be used to pull things out of the stomach in the other direction. The tubes that are most commonly recommended, and I would like to put recommended in quotes here, for people who have dementia and who are losing weight, are the percutaneous endoscopic gastrostomy, or PEG tubes. PEG tubes are inserted in an operating room, but the person is not fully asleep. They're just kind of gently sedated. This tube goes from the stomach, so it's inserted down through the mouth. From the stomach, an incision, a cut, is made in the stomach and in the wall of the belly, and the tube is poked through to the outside and then anchored there. They can be left in place indefinitely. And people can be fed through them directly into the stomach. They can leak around the opening in the belly, and when that happens, you can get kind of maceration of the skin, where the skin, like if you've had a wet Band-Aid on too long, what your skin looks like under that is maceration. They can cause infection there in the wall of the belly itself. They can clog, and that happens not unusually. They do clog. And a person who's confused, like someone who suffers from dementia, can pull them out. They just, you grab the tube and you can just pull it out. As a consequence of that, people who have dementia and who have PEG tubes are frequently restrained, so tied down, or they have mittens put on, or they're sedated a little bit so that they don't pull out their tubes. And people who are restrained and sedated are at much greater risk of all kinds of bad things happening to them. Falls out of bed, skin breakdown because they can't move properly, more aspiration because they're not awake really, and other problems. This is a picture of an otherwise quite healthy looking man who has a PEG tube. So this is what it looks like from the outside. There's a little button right next to the skin that holds the thing in place. There's another button on the inside that holds it in place in the stomach. And as you can see, the tube has a valve at the end that can be opened and closed and can be attached to another tube that can have liquid food travel through it into the stomach, and it goes directly into the stomach. So the reason that you might consider doing this in someone who suffers from dementia is to try and correct problems or prevent problems. And I'm listing here the problems that you might be trying to deal with. So, do they improve nutrition in people who are not eating well and who are losing weight? Well, this has actually been studied quite extensively, and extremely counterintuitively, they do not do that. People who have dementia, as I mentioned before, have relentless weight loss. It's part of the illness. And putting in a tube and giving them extra nutrition that way does not reverse that problem. You would think that it would, but it actually doesn't. Sometimes tubes are put in for people with dementia who have repeated bouts of aspiration pneumonia, in the hope that this will prevent their aspiration pneumonia because they don't need to swallow. However, this has also been studied, and people with dementia who have PEG tubes actually aspirate more than people who have the same degree of dementia who do not have PEG tubes and who are fed by hand. So again, this is a little counterintuitive, but you can't argue with the facts. So instead of preventing aspiration, it actually increases the likelihood of aspiration. People have also looked at whether someone who has a wound, like a pressure wound, might heal their wound more quickly if they were getting more nutrition through a PEG tube. And, no, that doesn't happen. And in fact, people who have PEG tubes tend to develop more pressure wounds. They also don't live longer. than people with comparable levels of dementia who are fed by hand. They don't regain strength. They don't regain function. So a PEG tube actually does not solve any of the problems you might hope that it would solve. And in addition, from my perspective, people who have advanced dementia don't often have a lot of personal interaction with other people. They can't have conversations. They really have very limited abilities to interact. So if you have to feed someone by hand, and it takes a long time, and you have to feed them these little bites, then this may be, especially in a nursing home, the only personal face-to-face interaction that person suffering from dementia may get over the course of the day. And I think that that's a very important thing. But, that's an emotional response of mine, and the actual science is that PEG tubes don't help anyway. So it seems like a simple decision to me. Okay. What about coughing? So coughing is your friend. Coughing is a reflex that occurs when food or liquid starts to go the wrong way, and your body responds with a cough to clear the trachea, to move that stuff, whatever it is, back up into the mouth so it can go down the esophagus. So someone who coughs when they eat, that's a good thing, because it means that they have maintained that reflex. Many people lose that reflex as they get older, and they don't know, particularly as they get demented, as their dementia progresses, not so much in normal aging. Excuse me, but they don't know that the food or liquid in their mouth has gone the wrong way. They don't feel it, and so they don't cough. So if someone coughs during meals, that's fine. Let them cough, let them clear it out, wait a bit, and then you can proceed. And here are some resources that have been kindly presented by the Alzheimer's Foundation that is sponsoring this webinar. I have come to the end of my slides, and I am now going to turn it over to our organizer, and we can take questions if there are any.
Thank you so much. So yes, we are now live for questions or comments. Again, for any questions, please go to your right-hand side in your control panel, and you could type in your questions, and I'd be happy to read them to Dr. Weintraub. So we have a lot of thank yous coming in saying that this has been a very beneficial presentation. We have a question. She's a social worker in a nursing home, and she asked if you know of any books that she could recommend to family members regarding changes in eating patterns.
Oh, goodness. I don't. There are medical literature reviews but I am not aware of any lay literature on this topic. I'm sorry, that would be a really good thing to have, but I have never seen that.
Okay, thank you. So we have a question. You mentioned straws were bad, but what are your thoughts on straws with thickened liquids? It has seemed to work for us, with my family member in late-stage Alzheimer's fairly well.
So, thickened liquids, thickened liquids are easier because they're thick and they don't splash around. So, if you can get it through a straw, excuse me, if you can get it through a straw, then that might be okay. I mean, especially if it's working for you, then it's working. So that's good. I would not, if it ain't broke, don't fix it. But mostly the problem with straws is with thin liquids. The other thing that you can do with thickened liquids, because sometimes they're just too thick to go through a straw, is you can use things like sippy cups, that prevent spillage.
Thank you. Do you have any info on why people living with dementia tend to put liquids into their food before eating? I've seen this with countless patients, and I haven't been able to find an explanation.
You're saying that they, pour their milk into things before they eat it?
Yes.
No, I don't. It could be that it's a function of being confused. It could also be that it makes the food moister and easier to deal with as a consequence, because as I said, people don't have normal aging results in a reduced production of saliva. So it could just be sort of a response to that, to the fact that it just feels better when it's more moist. But those are guesses.
Okay, thank you. What are your thoughts about wandering behaviors and finger foods? Risk for aspiration or choking?
So you mean just like carrying a pretzel around with you or something? I think that's what is being asked.
Right.
That when someone is walking around, is it okay for them to, eat at the same time? What I would say is every person is different, and every person has different problems with swallowing. So if you have someone who likes to walk around and nibble at the same time, and it's not causing problems, then it's not a problem. If you find that there's choking involved or aspirating involved, then it is a problem. So, I don't think that there are hard and fast rules that you can apply to every person in every instance. And caring for someone who's suffering from dementia, a lot of it is trial and error and seeing what works best for that person, because every single person is different.
Thank you. Have you seen the Eat Well assistive tableware for dementia for individuals living with dementia? If so, is it worth the expensive price tag?
So I'm not familiar with that particular brand. I think there are, when I look online, there are many different brands of very similar things. So I would say it makes sense to go with a less expensive version of the same thing and see if it works, because there's no magic here. You want utensils that are easy to use, that you're not going to hurt yourself with, and plates that don't move around and that you can push against. And there's no magic utensil that's going to make someone remember how to eat. So I would go with cheaper versions of similar things myself. But I have to say, again, I'm not familiar with that particular product.
Thank you. How could a person tell the person living with dementia just did not like the food? Do they spit it out or refuse to eat? So how could you tell if a person living with dementia just didn't like the food, if they spit it out or refuse to eat, or if there's an actual problem?
Well, I think, again, it's a trial and error thing. I mean, if presented with food that is refused or spit back out, you then have to try other foods and see if every food produces the same response, or if some foods are yummy and get eaten and some foods get refused. I mean, just like everybody else, there are certain things people won't eat. My husband won't eat lima beans. And if I'm sure that if he were to suffer from dementia and I tried to feed him lima beans, he'd spit them right out. But, if I give him chocolate pudding, it would be a go. So I think it's really a question of searching for things that people like to eat, and sometimes you'll find them. And sometimes they'll be surprising. They'll be different from what people like to eat earlier in their lives. So it really is just a potentially frustrating problem, but you just have to look for foods that people are willing to take.
Thank you. What is the best way to deal with pooling of foods in a patient's mouth?
That's a really hard one. So it depends on how long it's been sitting in there. I mean, if it's sitting in there 2 hours after a meal, then I think if you can safely kind of fish it out, then that's the best thing to do. If it's during the meal, then sometimes you can offer people sips of liquid in between bites of solid food to help them move that solid food down. And sometimes it's really just a question of slowing down the process and feeding over long periods of time.
Thank you. For those patients with dementia who recognize and find puree completely visually unappetizing, and sometimes it is, what foods do you recommend we use to introduce this consistency? For those patients with dementia who recognize and find puree foods unappetizing, basically she's asking what foods do you recommend they use to introduce this consistency?
You mean because puree looks nasty, I guess, is the question. Well, you can start with purees that people are used to, eating that way. So pudding is always pudding. Beef stew is not always mush. It may taste delicious, but it may look terrible, sort of this nasty gray color. So I would start with things that people are used to, that people expect to be mushy. Remember, we tend to think of meals going in a particular direction. We start with appetizer, perhaps, we then go through entree, and then we get to dessert at the end, which is the sweet part. That doesn't have to be the case in someone who is suffering with dementia. If you can get them to take a bite of something sweet, like pudding that they expect to be pureed, and then give them a bite of, pureed chicken soup. If that works, fine. Who cares? It doesn't matter. It's, it all goes into the same place. So I would try starting with a pureed food that they're expecting. Applesauce is always applesauce. It's never solid.
Thank you. We have another question. What about compulsive eating in dementia patients?
So occasionally we do see this. We'll have people who have forgotten that they ate, and they'll think that they haven't eaten, and they remain hungry, or they think they remain hungry, and they'll take other people's food and start fights and just want to eat. And some of that is just for reasons that I certainly can't explain, and I don't think anyone else can. Thoughts get stuck in people's head. I have to eat, I haven't eaten, I need to eat now. And I think the best thing to do in that situation, just like with other potentially difficult behaviors, is to distract. So if someone finishes a meal and 5 minutes later says, "Where's my lunch?" The best thing to do is to not argue, but to see if you can redirect them to do something else. You say, "Oh, well, we're going to go out and get your lunch." Remember, fibbing is your friend with people who suffer from dementia, and perhaps you can redirect and go for a walk. The other thing is, you don't want to have triggers around, so that if someone is a compulsive eater and is eating everything in sight, don't have any food in sight except for during meal times. You don't want them to walk past the fruit bowl and say, like, "Oh, there's fruit. I must be hungry. I need to eat all of this fruit now." So reducing the availability of triggering and distracting and redirecting are your best friends. Arguing never works. You cannot win an argument with a person who is suffering from dementia.
So we have a couple of questions left. I know we're at 1:53. Is it okay if you take a couple more questions?
Sure.
Okay. So a question is, when brushing teeth becomes difficult to do well, do you have any additional tips on keeping patients' mouths as clean as possible?
Yeah, well, there are rinses, like a chlorhexidine rinse that you can use. It's an antibacterial rinse if you can kind of squirt it into somebody's mouth. There are also, if the problem is not liking the brush, there are swabs that can be used instead of brushes. And then, this is going to sound bad, but if there are just like a few teeth that are really not particularly useful and that are in not such good shape anyway, you might consider having them removed. And then you have, although you still want to try and maintain hygiene in the mouth, as I said before, if you don't have teeth, it's much easier. So I'm not suggesting taking someone who has wonderful dentition and all their teeth are fine and having all their teeth pulled. But if you've just got a few kind of really nasty ones, you might want to consider that.
So another question is, if the dementia patient has diabetes, is it still okay to give all the sweets they want?
Well, generally speaking, if someone has lived long enough with their diabetes to develop a dementing illness, they probably have type 2 diabetes, and there are medications that you use to control it, and we are looking for much less tight control in older people generally than we are in younger people, because the damage that high blood sugar does is measured in terms of years, decades. And someone who is suffering from advanced dementia isn't going to live that long to have that problem anyway. So yes, I would say that you want to avoid weight loss if you can. You want to feed them what they like, and try and keep their blood sugar, from going completely insane. But we look for an A1C in this setting of less than 8.5 or 9. So that's pretty generous control.
Thank you. We have another question. It sounds like you don't recommend feeding tubes, that they don't help very much. But if a person can no longer swallow, what options are left?
So let me just say that there are some settings in which feeding tubes are useful and I believe medically indicated. Someone who has had a stroke and has lost the ability to swallow acutely from their stroke, that is a situation in which a feeding tube is indicated because they may recover. Even up to 2 or 3 years later, they may recover their ability to swallow, just as they may recover their ability to walk or to speak. Someone who has suffered from dementia long enough so that they are at the point where they swallow poorly is at the end of the disease. And it's unlikely that they can't swallow at all. They probably can't swallow well. But it has been shown that even if you insert a feeding tube into somebody like that, it's not going to prolong their life or prevent any of the other problems that I listed. So then you are really basically, if the swallowing problem is a consequence of very advanced dementia, then you are really dealing with the end of the road. And, putting in a feeding tube is not going to change that. So I am opposed to feeding tubes in dementia because they don't work. For all of the things that we wished they worked for, they don't. And I think it is kinder to allow people to have the pleasure of the sensation of food in their mouths. There are very few pleasures left to people who are in the advanced stages of this disease and who are basically dying from it. I think the goal is comfort. And, I don't want anyone to take my chocolate pudding away from me at the end. So it's a combination. My reasons for being opposed to the insertion of feeding tubes in the setting of dementia as the reason, it's twofold. One is it doesn't work, and the other is I think eating is a comfort. That's an emotional response on my part. But the first part, the fact that it doesn't work, that's actually been demonstrated.
Right. And I think you said in the beginning for anyone who has questions specifically to their person, I know that was a kind of a general question, but for it's different individually. There's different preferences, and for the family to speak with the covering physician, have a care plan meeting, really educate yourself on the pros and cons. And I know we, reviewed that in the beginning, but thank you for sharing that. We do have another question. Would you recommend pizza as an okay food source for someone in late stage? Trying to get my mom on board. No more pizza for dad, but I believe an expert needs to be the one to say so before she listens.
So, so I really, as I said, I can't speak to your individual situation, but I think it's a question of what a person can manage. So if someone has advanced dementia and has a favorite food that they really want and they can manage to eat it without choking on it, then that's fine. We're not worrying anymore about somebody's cholesterol level. That's not what is going to cause them to pass on. It is the dementing illness. And so it's really a question of safety. And so if someone is able to eat their favorite food safely, then fine, let them eat their favorite food. If not, then you have a problem. And maybe there's a way to figure out which part of the favorite food is safe, and can you, duplicate that taste in some safe way. It would require some experimentation, but it's really an individual issue. I would not worry about trying to reduce somebody's cholesterol intake. People who have salt problems, people who have congestive heart failure and can't tolerate salt, that's a different story. You don't want people going, having exacerbations of their congestive heart failure. But otherwise, fats and so forth, that doesn't matter anymore.
Well, I want to thank you for your time. I know we're a couple minutes after scheduled, 1 to 2. I'm sorry we weren't able to get to any questions, but we tried to answer most of them and all of them. I know that we've been getting so many thank yous and so many positive comments of how great this presentation was today. I certainly learned new information, which I'll use in my daily practice. I also want to thank everyone for joining us today. Today was a great presentation. And of course, Dr. Weintraub, I can't thank you enough for volunteering your time and expertise and taking time to answering all these questions. We thank you, and I want to welcome everyone back to next month's presentation, or rather, I apologize, we're having a special edition on 8/15 from 1 to 2 p.m. Eastern Time, and it's about grandparents and taking care of individuals and their grandchildren and the impact on the family as a whole. So that should be an interesting special edition. So I hope everyone has a good rest of the day, and I welcome all back for the 15th for our special edition Care Connection. Thank you.
Thank you.
Thank you, Doctor. Have a good day, everyone.